Hello, everyone. Okay, so you all can hear me. Good, good. Okay. I'm going to turn to Heather. Are we ready to get started at this point? Okay. I guess we are live. I just want to say good afternoon to everyone. I just waved at everyone a moment ago. And those who are watching at home, I guess most of you are watching at home. Thank you for joining us this afternoon for another virtual meeting of our Commission to Study Mental and Behavioral Health. This is our second virtual meeting. Our first was back in June. And of course, that was after the coronavirus pandemic, had really changed how we did things. Prior to that, we had a meeting back, I guess it was in February, I believe. I don't have it in my notes, but I know that as the virus had, spread through Maryland, we made it more difficult for any of us to do in-person meetings, and particularly large group meetings. So I want to, thank you all for logging in and continuing to participate in this very important commission, something that I feel very strongly about. Now, I will say just a few things about the pandemic. Fortunately, we're in a situation where we're not in as dire straits as we were a couple of months ago in terms of the infection rate, the positivity rate, the hospitalizations, and a number of other key metrics that we were following. And so we've been, working very hard, particularly the governor, in terms of making sure that there's greater awareness, that our resources are being placed in the areas that can help the most people get through this process. We're happy to say that we're making progress in all of our key metrics, particularly, as I said, the positivity rate is low. We're even seeing there was a little bit of an uptick a couple of weeks back. I guess it was in early July. We were seeing an uptick amongst younger people. Many of you on this call, 35 and below, and feeling like a old man wanting to yell at the kids to get off my grass or something. We were seeing a positivity rate increase with them, but in recent weeks and days, their positivity rate has come down. And so we're very pleased that that is happening. And so that has allowed the state to start opening up more of our economy, to get people back working. And we've just announced last week that our unemployment rate had dropped. It's still not anywhere near what it was back in January and February, but it is moving in a positive direction. Our unemployment rate is lower than our neighboring states and substantially lower than the national average. But, as anyone will tell you, we're definitely not out of the woods. We're still dealing with the virus. We are all still dealing with it. But we're hopeful because we're seeing that our health metrics are improving. And so long as we continue to follow the public health guidelines, wearing a mask, appropriate hygiene, washing your hands, and maintaining social distancing, we will get through this. And so it means for the time being, we will be continuing to meet virtually. I know that everyone probably on this call is having virtual meetings and Zoom meetings and things of that nature. We're glad Zoom is back. And so we had talked about it, I think, in the last meeting, how this pandemic affects the mental health of individuals. And when you talk about dramatic job losses and loss of connection between people, it has an adverse effect on our mental well-being. And so as we can be heartened that, folks are getting back to work and there may be more socialization that starts to take place, we still have to work very hard for those individuals who are suffering from mental health issues to make sure that they're getting the services that they need and that us in the positions, people like myself and some of you on the line, the policymakers, understand those challenges and continue to work to make sure we take down those barriers to getting services to those individuals. So before I get into the agenda, I do want to welcome two new members to this commission. First, a new acting assistant secretary for the Department of Human Services, and that's Tiffany Rexrod, who is replacing Dr. Randy Walters and is the co-chair of the Youth and Families Subcommittee. So Tiffany, welcome aboard. I see you down in the corner of my screen. Welcome, Tiffany. I also want to introduce our sixth public member to the commission. We went a whole year without a sixth member to the of the public to the commission, and that's Kimberly Watts. Kimberly, thank you. Oh, I see you over on the other side of the screen. Kimberly is an assistant public defender with the Office of the Public Defender's Forensic Mental Health Division. And so, Kimberly, thank you for volunteering to join us. Your voice will definitely be needed, and we're glad that you're here. So at this time, I'm going to go around, do kind of a roll call and ask the commission members just to introduce themselves very quickly. And I will read off the names, and then you can introduce yourselves to everyone else. I've already introduced myself, or maybe I didn't. Senator Eckert.
Good afternoon, everybody. Glad to be here on this summer afternoon. Senator Audie Eckert. I'm a psych nurse by background, and I represent Dorchester, Talbot, Caroline, Wycomico counties on the Eastern Shore.
I guess I shouldn't just mute myself too quickly. Senator Hester.
Good afternoon, everyone. Senator Katie Hester. I represent Howard and Carroll County. An ag bioengineer by training, and currently co-chairing the subcommittee on criminal justice and safety in this commission.
Okay, thank you. Nice backdrop.
Thank you.
Delegate Young.
Good afternoon, everyone. I represent District 3A, which is largely Frederick County. I sit on Health and Government Operations, and in my prior life, I was in banking and financial services.
Okay. Tricia Roddy is here representing Dennis Schrader from the Department of Health.
Hi, good afternoon. I'm Tricia Roddy. I'm the Assistant Medicaid Director for the department, and I've been with the program in various roles for about 19 years now. So I'm glad to have joined you, and I'm very interested in the conversation today. Thank you.
Okay, thank you. Dr. Jones.
Hi, good evening. This is Aaliyah Jones, Deputy Secretary for the Behavioral Health Administration for MDH.
Okay, thank you. Is Major Butler on the line? I don't see Major Butler. Okay, so he's not here. Public safety and Dr. Vanesky, did I get that right?
Yes, sir. Hi, I'm Dr. Linda Vanesky. I'm the Acting Director of Mental Health for the Department of Public Safety and Correctional Services and the Acting Director of Patuxent Institution. And I'm a licensed psychologist, so I'm happy to be on this commission.
And Tiffany Rexrod, did I get your name correct, Tiffany?
Yes, thank you. I'm Tiffany Rexrod. I'm the Acting Assistant Deputy Secretary for Programs for our Department of Human Services. Very happy to be with you. Thank you.
Thank you. Welcome aboard. Commissioner Bahrain.
Hi, I'm Kathleen Bahrain. I'm the State Insurance Commissioner. I am a lawyer by training and a former mental health professional. I too am delighted to be with this group, and I co-chair the Finance Subcommittee.
Okay. Director Hsu.
Good afternoon, everyone. I'm Steve Hsu, Executive Director of the Opioid Operational Command Center, and I'm chairing the Crisis Services Subcommittee for this commission, and it is a pleasure to be with all of you today.
Okay. Mary Gable.
Good afternoon, Lieutenant Governor. I'm Mary Gable. I'm Assistant State Superintendent with the Division of Student Services, Academic Enrichment, Educational Policy. Thank you for being here.
Thank
Appreciate
you.
being here.
And our public members, Barbara Allen.
Hi, I'm Barbara Allen. I am the Executive Director of James Place. We do scholarships for folks moving into recovery housing and a lot of advocacy. And I co-chair the Behavioral Health Advisory Council with Lauren Grimes. That's me.
Okay. Thank you. Pat Miniszewski. Did you, wait a minute, I think you're still muted, Pat.
Yep, sorry about that.
Oh, there you are.
Hi, everyone. I'm a family advocate with lived experience, and I'm a registered nurse. Thank you.
Okay. And Dr. Rao, remind me how to pronounce your last name.
Tripurneni. I'm Dr. Tripurneni. I'm an associate medical director working for Mid-Atlantic Kaiser Permanente, and I'm a child and adolescent psychiatrist by specialty.
Okay.
I'm glad to be here.
Well, thank you. Carrie Cho.
Good afternoon, everybody. I am Carrie Cho. I'm the CEO of Cornerstone Montgomery, a behavioral health nonprofit in Montgomery County. I'm very glad to be here.
Okay. And Serena Eckwood.
Good afternoon, everybody. Serena Eckwood with NAMI, Prince George's County. I'm also a family mental health advocate as well. Glad to be here.
Glad to have you. And Ms. Watts. Kimberly Watts.
Hi, I'm an attorney with the Public Defender's Office. I've been working there for 20 years, and I'm currently in our Forensic Mental Health Division. So that means that I assist our line attorneys with getting experts in mental health cases, in addition to trying a number of them myself. And I also am on the Behavioral Health Advisory Commission with Ms. Allen. My capacity is someone who has a family member with mental illness. So I'm really excited to be a part of this. Thank you.
Okay, thank you very much. And I just misplaced my agenda. Oh, okay, I got it now. All right. Let's see. We don't have minutes from the last meeting. Oh, okay. I don't know if everyone has had a chance to check the minutes. Oh, we don't, I was just advised, we don't have actual minutes. We have the recording of the minutes on the webpage. If anyone who does want to listen to the last meeting, they could go to our webpage and pull up those minutes, or pull up the meeting, I should say, and actually listen to the meetings, which would be more detailed than minutes typically are. I'm going to turn to subcommittee reports, and we'll start with the Crisis Services Subcommittee. I think that's
great. Thank you, Lieutenant Governor, and thank you also for organizing this commission and for your ongoing leadership on this incredibly important subject matter. On behalf of the OOCC, the Opioid Operational Command Center, I'd like to thank all of you for being part of this commission and for your interest in this topic. I'd like to provide the group with an update on recent activities of the Commission's Crisis Services Subcommittee. Since we last met in June, the subcommittee has continued to prioritize the development of a comprehensive statewide crisis services system. Coronavirus has certainly added urgency to this work, and that urgency increases every day as we learn more about the pandemic's effects on behavioral health. We have more objective evidence than ever that the pandemic has harmed the mental health and aggravated the substance use issues of Marylanders. Right now, we need a crisis coordination infrastructure upon which we can rely. Since May, the OOCC has been working with various partners, including the Behavioral Health Administration and the Maryland Medicaid Administration to coordinate several work groups that are focused on improving crisis service offerings here in Maryland. We found more efficient ways to fund these groups' activities, and we found more efficient ways to utilize each group's strengths. Together, we're finding ways to maximize the capabilities of the state's outpatient mental health centers, or OMHCs. It is our hope that existing OMHCs will offer a convenient and efficient outlet for the delivery of a full suite of crisis services in jurisdictions throughout the state in the near future. We are pleased that just yesterday, the Maryland Medicaid Administration was awarded funding from the OOCC to help operationalize this concept. The Crisis Services Subcommittee will host a virtual subcommittee meeting on September 2nd from 10:30 a.m. to 12 noon. We'll hear an update on the development of the crisis services system from Stephanie Slowly, BHA's Chief of Staff. We will also learn about projects that will be funded in fiscal 21 through the HB 1092 Crisis Services Fund, which BHA administers. And finally, we'll receive an update from the Governor's Office of Crime Prevention, Youth, and Victim Services on the establishment of the Crisis Intervention Team Center of Excellence. More detail and login information for that meeting on September 2nd are available on the Lieutenant Governor's website under Mental Health Commission tab. Thank you again for your continued attention to these issues and for your collaboration. Maryland's sustained commitment to addressing the behavioral health needs of our citizens is more important now than it ever has been, and the OOCC is here to help in any way that we can. Please contact us at help.oocc@maryland.gov if we can be of assistance. Back to you, Lieutenant Governor. Thank you.
Thank you, Director Chu. And I guess I just want to note that, and seeing some preliminary numbers, it appears that we're seeing I don't know if we call it a resurgence, but increase in the amount of people that are succumbing from substance use disorder. And as we all know, there are co-occurring conditions with mental illness. And during this time of the pandemic, the stress associated with the pandemic, the distance, not being close to one another is exacerbating challenges that people already have, the feeling of isolation and just the uncertainty of what can happen means that we will redouble our efforts in all these areas and not just think in terms of the physical health of individuals, but also their mental well-being as well. So, thank you for your work, and we'll continue to push forward. I skipped over very important. I'm sorry.
Yeah.
Yes.
This is Pat. I just
Yes.
wanted to point out that our last crisis services meeting, that we heard some really exciting ideas around what they call MTAC teams. And these are ACT teams with now a crisis component attached to them. And that is another way that we can use ACT teams at another level to provide crisis services that will become co-occurring capable, and that they would be able to treat both disorders. They have members on there who are nurses, who are psychiatrists, and they're both substance use and mental health clinicians who are able to come together, and integrate as a team, so that it's just a great concept. And we're hoping to get to that next level from the ACT teams. So, I just wanted to point that out, that it'll give us more continuum of care, and it will give us another treatment modality that we've not seen before. And it's pretty much the fiscal note is not really that big. So that's good to know.
Okay. Well, I know that, and I think I spoke about this a while ago, that Calvert County, I know, has I think it was Calvert. Um, they used one of the grants that came through the OOCC that to purchase a vehicle for both substance use disorder and mental health crisis. I believe they had started with the substance use side of it, and they were moving toward the mental health crisis. And I believe it was Calvert County, a mobile response team for people that were in crisis. So, so there, I know that there's efforts taking place. So
Yeah,
we need to get a better hand.
that was exciting. Steve had someone present it for us, and was really interesting.
Thank you. I had accidentally skipped over Christian Mealy when we were going through the introductions. Christian on the line?
Hey, Lieutenant Governor. Good afternoon, Commissioners. Christian Mealy, Deputy Secretary of the Department of Disabilities.
Okay,
and,
thank you. My apologies for skipping you. I don't know how I did that. But, okay, Youth and Families, the subcommittee.
All right, well, I guess we'll ping pong it back to me.
Go right to you, Christian.
Yeah, and my apologies on the office computer. I don't have a webcam, so I was trying to find a picture of you and I, LG, from a previous escapade, but I haven't been able to figure out that. For a millennial, I'm pretty bad with technology. At any rate, I wanted to also introduce my new co-chair for the Youth and Family Subcommittee, Tiffany Rexroad, who you already introduced, but we're very excited to have her on our team. And we think, given her professional background, she's going to add a lot of value to our subcommittee. And so she and I met prior to this meeting, and she actually is going to be giving our brief subcommittee report, and we're excited to move forward as a team. So, Tiffany.
Thank you. Thank you, Lieutenant Governor and Secretary Padilla, for this opportunity to work in partnership with you. Just a brief overview of my background. I have a master's degree in social work, and I'm a licensed clinical social worker in Maryland. And for the past 19 years, have worked in Washington County to support children, families, and adults to live safely in their community. With respect to the Youth and Families Subcommittee, we have issued a scheduling poll and intend to set a standing meeting date and time. We are very interested in reviewing the impact of COVID-19 on youth and families. Finally, I want to thank Christian Mealy. I look forward to our collaboration. I'm very excited to engage with you, the commission, members of the subcommittee, and our community partners to further the goals of this commission. Thank you.
Well, thank you. Okay, the finance and funding, and I think Tricia Roddy is going to present that.
Yes, and then I'll pass it over also to Commissioner Brain.
Oh, okay.
So again, we both co-chair it together. We have had 2 meetings of the Finance Committee, one back in June and one back in the beginning of August. The first meeting was a real touch base to kind of get us back together. We hadn't been meeting because of the COVID-19 and we were on pause. We touched base and we talked 2 issues that we talked about from the Medicaid perspective is we talked about one, that we were starting up to begin to develop cost-based rates for the behavioral health providers in Medicaid. That's a requirement under the HOPE Act, and we had kind of put that on pause during COVID-19, but we're starting to re-engage in those activities. It will involve a 2-phased approach where we develop a contractor to work with the providers to get a standardized cost report. And then and there'll be a lot of technical assistance provided to providers during that first phase. The second phase will actually be developing the rates. So we're anticipating putting out the RFP sometime in the fall. And then secondly, our Behavioral Health Administration under Dr. Jones did a very nice survey of how telehealth has been impacting providers during COVID-19, things that they like about telehealth and things that they don't like about telehealth. So there's lots to learn from that survey. And the Behavioral Health Administration is continuing to engage on additional surveys. And then, our second meeting, the Medicaid program, really kind of touched upon also what the federal waivers we've been able to obtain around telehealth during the pandemic, and then also what we've been able to authorize just through the governor's executive orders and Secretary Neal's directives. So we had a very good discussion around that, and we're looking forward to getting the group back together in September. With regards to the commercial carriers, I'm going to turn it over to Commissioner Barain and let her kind of discuss what we discussed around those topics.
Sure. Thank you very much, Tricia. I appreciate that. With respect to the private insurance network adequacy focus area, the first topic that we looked at was the 2020 access plans. The access network adequacy reports were due and received on July 31st, 2020. I'm sorry, July 1st, 2020. We received plans for 23 networks across 6 different carrier groups. The initial executive summaries that were filed by the carriers have been posted to the MIA website and are available to you there. In summary, what we noted was that many of the carriers reported significant improvement in compliance with the metrics specified for mental health and substance use disorder providers, but there was some backsliding, some deterioration in compliance. And frankly, all the plans failed to meet the required standard for at least one of the metrics. Only 2 of the carrier groups requested a waiver of 1 or more of the standards. The MIA had published Bulletin 2027 on June 16th, which granted flexibility to carriers to file updated information in their network adequacy plans after July 1st if the impacts of the pandemic had negatively affected a carrier's ability to ensure the data reported on July the 1st to make sure that it was accurate and reliable. The updated information is due no later than September 1st. Any carrier requesting the flexibility had to identify a complete description of the deficiencies or limitations of the initially reported data with their July 1st filing. Only 2 of the carrier groups requested to provide updated information after July 1st. We expect to receive that by September 1st, and obviously we'll incorporate that into our considerations. The second topic area is with, of course, the Network Adequacy Work Group. As you all know, the MIA had convened a stakeholder work group last fall to analyze the MIA's existing network adequacy regulations and identify areas for improvement. The meetings were temporarily suspended due to the pandemic, but they've recently resumed, and the last public meeting was held virtually on August 5th, 2020. It was a broad-ranging, I think, very successful meeting, and during the meeting, a variety of topics and ideas for revisions to the regulations were discussed. Consumer advocates and provider associations for mental and behavioral health have consistently been the most engaged and vocal participants, and that's a really good thing. The work group set a deadline for submission of written comments for August 19th. We have received a number of written comments. We're reviewing them and we'll be incorporating them into what is really now our next step, which is to prepare revisions to the regulations. There will be more public meetings after that. We will post them. In addition, and in the interim, the MIA is looking at, while we're working through and finalizing the draft regulations, having one more meeting that's focused primarily on telehealth. What have been the benefits of telehealth and frankly, what are still the challenges of telehealth. And so how does it work well as a tool to improve access, and where are the challenges, and where is telehealth itself not really fully accessible? The third topic, of course, is telehealth. The MIA has been actively engaged during the state of emergency with carriers and other stakeholders to ensure appropriate measures are taken, really to respond to the unique adequacy challenges that came about as a result of the pandemics. I think by all accounts, telehealth services have been extremely helpful in addressing network deficiencies, including in the behavioral health and substance abuse disorder services. They're of course not perfect. The MIA had requested in March through bulletin that carriers encourage greater use of telehealth services. And ultimately, the MIA had determined that formal regulatory action wasn't warranted because carriers did voluntarily expand access to and coverage of services during the pandemic. And those kinds of accommodations included things like an expansion of the types of services eligible for telehealth, reimbursement parity, a broadening of the telehealth platforms that were approved, coverage of audio-only telephone conversations, waivers of cost sharing and telehealth services. As the state of emergency has continued, there are carriers that have begun to scale back on some of these voluntary accommodations. We're keeping a close look on that and monitoring the situation. It's our concern and our belief, however, that legislation is going to be needed to ensure that certain aspects of telehealth expansion are able to become permanent because of the structures of our laws and regulations. So that was our focus on the commercial insurance market.
Okay, thank you. Let me ask on the telehealth, you mentioned something about it potentially assisting in network adequacy issues. Did I get that correct?
Correct.
Okay. Yeah, but I know there was legislation that was passed at the end of the last session to expand telehealth services, but just my memory fades, but I believe it still was somewhat limited. Wasn't it limited just to audio and not full audio, video services?
So the definition for telehealth is that it would be both audio and visual at the same time. So you would have to, in order to qualify as telehealth, you would have to have both an audio and a visual component, which can be limiting because there are circumstances where people don't have, the availability of the video portion of it, or don't have broadband, or they just don't have that capability. So one of the things that was good in the pandemic was carriers have allowed audio-only consultations, although there hasn't been parity of compensation in instance. The other thing is that the legislation did not address parity of compensation. So, you can have, the audio-visual consult, or you can have the in-person consult, but they were being reimbursed at drastically different rates. One of the things carriers did as an accommodation was with respect to many services, they created economic parity for the providers for the telehealth audio-visual consultations. That is something, however, that is purely an accommodation on their part, and the legislation doesn't address that at all. So those are the kinds of things where, to the extent we see telehealth, and telehealth does have a role to play in network adequacy, are things that we're going to want to address. The legislature, I'm sure, is going to take up in the next session. We also have to think about how telehealth fits into the adequacy conversation when not everybody has access to what you need to participate in telehealth.
Right, to fully participate. Okay, all right. Excuse me, what was the first area? I know the second was adequacy, the network adequacy and telehealth. What was your first area again? The first, you mentioned three.
Our 2020 plans. So the
2020
by carriers.
All right, I didn't write that down. Okay.
Lieutenant Governor.
Yes, ma'am.
I'd just like to jump in here. We've had a behavioral health regional meeting go on a regular basis almost every week. And then for the past month, it's been every 2 weeks. And one of the things the clinicians report regularly in all the programs is that the phones have been a lifesaver because we just don't have broadband in so many areas on the Eastern Shore, and we're not going to have it for the next couple of years. I wish we could say we're going to have it. So we've had to go to bat to make sure we have additional minutes on the phones, and the phone companies helped out there. Then we had to go back and kind of clarify with the private insurers what constitutes a visit versus a follow-up, because apparently what happened when it came out that these would be included, everybody was calling on the phone. And so the utilization went sky high, and then it had to be reined back in by a number of the insurers. So getting that sorted out is really important. And I would suggest that we look at the parity between Medicaid, Medicare. It's a federal issue out of CMS, but I know everybody's been working to make sure we determine how we can continue to provide these services via telehealth in one way or another, recognizing the transportation issues and other costs in the rural areas.
Right, yeah. No, very, very good points. Particularly being able to qualify for audio only as telehealth services and the compensation coming in. Does Medicaid have any challenges on that side? I mean, do they, are they paying people?
We have a very expansive policy right now during the pandemic. I think in general, we pay like an in-service visit. So we have not differentiated the rate. We are paying the same amount even for audio only right now. We do acknowledge that that is allowed right now through the federal waiver under the federal emergency. And potentially that might go away after the federal emergency ends, which is now scheduled at the end of October. But we are looking at how we can continue to keep in place some of the provisions that we have allowed during the pandemic. For example, we've expanded greatly to the home setting. And so we have lifted the restriction that services cannot be delivered via telehealth while the individual is home. And so we have, that is a pretty broad waiver or provision that we've enacted. And that is something that the state can do on itself, continue after the federal health emergency ends. So we are looking at that as well.
Okay. So we're right now for the parity side for audio services, audio telehealth services, we're reliant upon the federal government to act, basically. Now, could they do it through regulation and not necessarily through statute?
So, I think the ruling around the federal government is they don't view audio only as the same type of service delivered via audio video or in person. So there's different codes and classifications for those services. And again, it would be paid at a different rate. And that's something we could look into as well. But it wouldn't receive the same reimbursement that an in-person visit receives today.
Okay. Now, I guess, but back to their interpretation of telehealth services, is that something that's in their statute or is it in their regulations? Because regulations are probably a little easier to get changed than statutes because Congress doesn't do much of anything. Oh, did I say that out loud? So.
I'm trying to think. I think it's probably in how we get what's called our state plan approved in terms of our services that get approved, whether it's specifically in statute. I don't know that, but it's in terms of how they would approve our state plan.
Okay, well, we'll look into it, and my office will check on that. So, okay. Public safety and thank you, public safety and justice system work group.
That's me.
Okay.
Sorry, just
That's all right.
Unmuted here. Well, thank you, Lieutenant Governor, and along with my co-chair, Dr. Linda Banowski, we co-chair the Criminal Justice and Public Safety Subcommittee. We've worked over the past month and a half to explore how we could implement one of our major recommendations from the 2019 report, which was the sequential intercept model here in Maryland. And at our first subcommittee meeting, we had a presentation on the SIM model by Public Research Associates, which I can share if anybody is interested. We actually had about 30 people on that subcommittee call. I think people were really interested, and several members of the broader committee were there. So thank you for coming. But just for those of you who weren't there, the goal of the sequential intercept model is to identify mental and behavioral health services at each intercept with the criminal justice system. So from community access to law enforcement to initial detention, court hearings, and community corrections. And obviously, as more resources go into the first intercept around community services, the less people wind up in the criminal justice system. But one of the challenges we identified is that there was a lack of a comprehensive map at the state level of these different linkages between the local and the state services and these different intercepts. And so we were thinking that if we could establish consistency and ensure kind of sufficient resources, that this map would really help us to be most efficient. And I'd just like to point out that several of our counties have actually undertaken local SIM maps at the county level, and several other counties have applied and haven't been able to get funding. So based on this kind of exploration, we reached out to SAMHSA, which is the Substance Abuse and Mental Health Services Administration, to see what kind of additional technical assistance they could offer. And today I'm very pleased to announce that they have agreed to provide technical assistance to the state of Maryland in the form of helping us to host a cost-free state summit on the SIM model, virtual of course, and then follow that up with a Train the Trainers program so that somebody from every county could learn how to implement this model. And I'd just like to thank both my co-chair and the Lieutenant Governor. We wrote letters of request, and somehow we got approved for this. So really happy that this is going forward. In terms of a timeline for the state summit, we're looking at mid to late October, which is about as fast as I think we can pull it together. And our goal would be of the summit would be have three things. First, to facilitate these discussions to identify the resources and gaps across the state. Two, to enable county work groups, people who don't normally talk to each other across the different intercepts, to meet and talk about their own counties. And three, the output, which the PRA consulting firm will provide back to us, is our list of recommendations and gap analysis for the state of Maryland. So really excited and happy to announce that. And then following it, probably sometime in the spring, this Train the Trainer session, so that local leaders can stand up and learn how to do a local map, in their own district. So our next subcommittee meeting is going to be also Wednesday, September 2nd. Looks like a popular day. Ours is at 2:00 in the afternoon. And if anybody wants to join us, we're hoping to have somebody from Michigan who's done a statewide SIM summit before, and somebody from, I'm going to get this wrong. It was either Cecil or Calvert County, but one of the local Maryland counties who's done this, to give us both their kind of retrospective reviews on how their SIM maps worked, and then start planning for the October summit. So really, really good news. I'm excited about this, and I think we'll uncover a lot of good ideas to take into next year.
Very good. No, it is exciting. Thank you for your efforts and your leadership in bringing this to Maryland, and at this particular time. I don't know, my screen froze up for most of your presentation, but the audio came in clear. You just froze. It looked like you had closed your eyes for a few minutes, but otherwise it was wonderful. So thank you.
Well, I'm glad at least you guys could hear me. I was sorry about the Wi-Fi. I must live on the western part of Howard County.
That's all right. Well, I'm right in downtown Baltimore City, and it just gave me a message that the internet was unstable. So that was, at least it wasn't a nuclear reactor. So at this point, we're going to go to a presentation from our great secretary, Rona Kramer, from the Maryland Department of Aging, and a program on aging program enhancements during the pandemic. And we've talked about just the isolation and the impact that it can have on all of us. And I think particularly those who are older, elderly, that may live alone or, just, in a empty nest environment, that they're separated from family members, particularly younger family members, grandchildren, and the like, who are staying away because they don't want to infect them. Those who may be in assisted living or senior living facilities, and limitations on visitors, and so that can have a significant impact on an individual's well-being, particularly during this time. So, Madam Secretary, thank you for agreeing to make a presentation today. I'll turn it over to you.
Thank you, Lieutenant Governor. It's great to be here with you. I appreciate having the opportunity to put on makeup and jewelry. And I want you to know that even though you can't tell, I smell pretty good too. So it's great to be here with you and to be able to share what we've been doing. And you were absolutely right in the list that you just gave of concerns that are very unique and specific to our older adult population. When COVID began to affect us in Maryland, it presented two major overarching concerns. One was that we at the Department of Aging had to deal with the provision of basic services, basic physical needs that we've always fairly broadly taken for granted, but that became extremely difficult for a very large percentage of our population, people who were accustomed to taking care of themselves previously. So we had to have the provision of food, medicine, as well as assistance for many people with activities of daily living, hygiene, ambulation. They were accustomed to having someone come into their home and assist them with some of these basic activities, generally family caregivers. And now they were afraid to let anyone into their home to provide services. So we did step up and have provided supports in all of those aspects: food, provision of medicine, and ADLs. The second that we knew we had to deal with was a great deal of fear and anxiety, isolation, as you noted, Lieutenant Governor, and depression. This group, we have to remember, is the group that faced the largest number of deaths in the state. They were dying in very large numbers. It was spouses and sisters and brothers, roommates in nursing homes, and they were experiencing this very, very personally, and the fear was tremendous. We also know that isolation and depression are contributors to dementia. So whatever was happening now could easily remain a long-term issue even beyond the pandemic. if we didn't do everything possible to intervene and reduce some of that fear, isolation, anxiety, and depression. Something else that you need to keep in mind as we were working to insert ourselves in their lives in a way to reduce those issues is that we had to be very cautious in using volunteers, in interacting through the internet or pen pal program or any other programs where we were introducing strangers into nursing homes, assisted livings, congregate housing settings, because unfortunately, scams against older adults is a huge problem. And we couldn't introduce strangers to them without having vetted them. And that has been a very big issue that we continue to deal with as we try to provide social services and interaction with older adults. One of the first things that we did was we wanted to provide information to prevent fear of the unknown. And so we started producing public service announcements.
Listen to this with a 1 ear.
Oh, it's okay. You can stop it. Thank you. Yeah, there's a link to it on the slide. But we produced, now we've produced over 40 public service announcements, and we've been rolling them out about bi-monthly so that they're updated, they're new, and they give a current assessment of the state of Maryland in the coronavirus. And so we've aired these public service announcements on television. They've aired on our YouTube channel. One of them actually had 27,000 hits on YouTube. We've sent them directly to 90,000 residents of congregate housing communities like Leisure World, continuing care retirement communities, many assisted livings and nursing homes, so that this would be available to as many older adults as possible. And the subjects were updating on Maryland's efforts. We had many that were specific to how a senior needed to deal with the pandemic and specific issues, such as when an older adult who uses a walker or a cane goes to wash their hands, as we're telling everyone, and we certainly did in the beginning, we hammered that home, wash your hands constantly. Well, they also had to sanitize the grip of their cane or their walker, or in fact, they were not really sanitizing their hand. As soon as they touched the grip again, they had reintroduced any virus that might have been on their hands prior to washing. We talked to them about the scams and let them know what kinds of scams were coming in, and they change constantly. So we have to update that information. And we did these with me personally doing all of these public service announcements, and I assure you it was not because I like the publicity, because I do not. But we felt in discussing this with the Department of Health that it was best to have a trusted appearance of someone who they could trust and they became accustomed to seeing, and it added warmth and an association to valid information. And so we are in the process of writing and taping. We will be another series as this is ongoing. We had slide 2, Angie, thank you. We had, prior to maybe a year before COVID hit us, rolled out Senior Call Check, which is a free service to all Marylanders 65 and older. And it is a check-in, daily check-in call so that we can do our best to prevent anyone from languishing on the floor after a fall or a heart attack, a stroke, without anyone knowing that they were unable to get to a phone to call for help. And so when COVID began, the governor mentioned this service in one of his press conferences. And we went from our early rollout numbers of participants of about 189 overnight to over 1,100 participants in the program. It was wonderful. We continue to have a much higher level of participants now. And we added to our program a pre-recorded message that went out giving them information about COVID, where they could get behavioral health supports, information about scams, etc. And we also added to this service and a weekly live check-in call. We recruited a group of AmeriCorps volunteers and once again had to be very cautious that these were vetted volunteers. And so they began calling, and it's once a week now, unless someone needs a more frequent check-in call. And then we provide as many days a week as the call recipient needs to feel comfortable, especially important for people who are living alone and in fear and lonely. We also trained these volunteers to recognize depression as well as elder abuse. Very, very important because we've seen a rise in, of course, both. And so then we can bring in our specialists and our programs where necessary, where we find that. Our area agencies on aging across the state also started doing personal check-ins by phone during meal deliveries and through virtual senior centers that have been set up across the state. We've used social media, and social media, we target not only the older adults themselves, but also adult children. We do have a large number, this is another barrier to our getting to the people who need our assistance, is that many of them don't use social media. Many of them don't have smartphones. They don't have computers or technology. And so we have a huge hurdle to get over to reach those people. But in social media, we have improved we use Facebook regularly, and we do have many adult children who use that and follow us there. We brought in new features to our website, links to the Department of Health as well as CDC where appropriate. We've posted a great deal of behavioral health information and resources. We always bring the resources with the information. And we've got links to how-to videos for using platforms such as FaceTime, Skype, and video chats. We encourage social interaction as much as possible by teaching and training those who have access to the appropriate internet. Slide 3, our AAAs, our area agencies on aging across the state, provide screening for behavioral health issues as they bring people into and enroll them in our programs. So it is a regular part of what we do. It has ramped up during COVID. And senior care is our largest statewide program where we provide very flexible supports to older adults. And so we can bring those participants into a program, for example, called PEARLS. It's a behavioral health program. It's an evidence-based program proven to reduce the incidence of depression and as well as the severity. And since the pandemic, we retrained all of our instructors in the program statewide to provide the program online or by phone so that we could continue and increase the number of people. And we had to get authorization, given that it is an evidence-based program, in order to do it. And we've been successfully functioning that way. All of our senior centers closed very early on in March. And so we needed to provide food. Many people had come to senior centers for congregate meals. I'll discuss that in a moment. But we had a huge amount of programming that our seniors across the state were very much dependent on. And everything from socialization to classes and courses to wonderful fitness centers in most of them. So our area agencies on aging began producing virtual senior center programming, a tremendous effort, and they have been very successful in doing so. They've included activities to promote socialization, as well as physical and mental well-being. So examples of some of the programs you can now watch online and participate in online are Tai Chi classes, yoga, meditation, and fitness classes. As we move into the next slide, I'll give you some examples of more specific programs. Slide 4. These are some examples of what the AAAs across the state have done in virtual programming. Baltimore County is offering over 100 online events to encourage social interaction. And some of them are programs from the Mental Health Association. Anyone from across the state can participate in these. So you don't have to be a resident of Baltimore County. Our AAAs and the jurisdictions across the state have been wonderful about sharing programming, so we're not reinventing the wheel in every jurisdiction. And it has allowed for participation in many, many wonderful programs. Charles County has a Facebook fitness challenge, and it's fun and it encourages people to keep moving as we are, many of us, remaining at home, especially our senior citizens. They are at home more than anyone else, getting out less than any other cohort in the state. Frederick County is doing a series of virtual tours of museums, zoos, national parks, sites, international sites like Versailles and Blarney Castle. And again, this is available statewide and interesting things to do. And if the Lieutenant Governor ever decides to give me a couple of days off, I might just get on and watch some of those. They really look like they're fascinating and interesting opportunities. Slide 5, Angie. We have a program in the state of Maryland that is expanding quickly that we rolled out about a year and a half ago, and it is Maryland's Community for Life program. And it provides services as a membership to anyone 60 and over who wants to join. It is available in 10 counties and the city right now, including the city. And It's a program to assist people in remaining at home years, hopefully decades longer than they will be able to without our services. So it's a membership program. There is a minimal membership fee, and we have a nonprofit provider in each jurisdiction that provides home maintenance, a service navigator, which is like a concierge of all the services available to older adults, and in that region specifically, as well as transportation. And that way we maintain their asset, their home. They have someone to go to for resources and a regular check-in call to make sure that they're not isolating, as well as we all know how important transportation is. So what we've done during COVID, we have changed the model to adapt. And we were not going into people's homes for at least the first 4 months of the pandemic, and some are still not. So we've put all of our efforts into going to using the service navigators and our home maintenance people to interact, making telephone calls, extra calls, and check-ins regularly. They're holding virtual social events for their members. They're setting up for their members. They set up Zoom calls, Skype, whatever, with family members and friends, so that we're giving access to people that wouldn't have known how to have access otherwise, and assisting with meals, groceries, and prescriptions. We also, separate program, had the issue of providing food and nutrition to tens of thousands of Marylanders who otherwise did not have the ability to go to the grocery store or to provide themselves or cook for themselves. So we added at the very beginning, as early in March, our numbers for home delivered meals went from 40,000 meals home delivered per week to 180,000 meals overnight. 180,000 meals delivered per week. It was almost a 500% increase. It has continued at that level throughout the pandemic. It still remains at that level, and we anticipate that that will continue for month to month. We think many more months. One of the things that we brought to the home delivered meals program was a restaurant meal initiative. And it, number one, we were putting a huge amount of new money into home delivered meals. So we wanted to support economic development and local restaurants to try to keep local restaurants alive through the pandemic, as well as providing meals that are that help improve one's spirit. We all know we're depending on food very heavily for excitement and interest. And this really ramped up the interest in meals. So we are now providing meals that are ethnically interesting and suited to different groups. We're providing Vietnamese, we're providing kosher meals, Southern style meals, Italian, Korean, Chinese, Peruvian, it goes on. And it gives our older adults, many of them, a sense of warmth when they see meals coming into their home that remind them of home. And many of our seniors did not grow up here in Maryland, and this gives them something to look forward to and something that's special. So we're very excited as we grow that program. So far, we've just in the week of August 15th, we've served 10,000 local restaurant meals. So I'd like to say that that is just the tip of the iceberg of what we're doing. And I'd like you to know that we are always open to new concepts and suggestions. And we innovate constantly at the Department of Aging and would love to hear back from any of you who have ideas for us. I'd also like to note the heroic work of the staff of the Department of Aging and all of our area agencies on aging across the state, because they have really stepped up during the pandemic. And I'd like to thank all of you. We're very fortunate. I was very impressed listening to the roll call for this commission. And I have to say that I never cease to be impressed by the quality and character of the people in Maryland who contribute their time on a volunteer basis to the betterment of our citizens. So from everyone at the Department of Aging, I'd like to thank you and tell you that we appreciate everything that you're doing.
Well, thank you. Thank you, Madam Secretary. That's very, helpful and good to know. You're providing so many services to individuals that need that, basically life-saving support, life support that's going on. When you talked about the restaurant delivery, we know that, a lot of the people, many on this commission who are far younger than me and are more involved in the 21st century are using meal delivery. I'm still an old timer. The only meal delivery I get is a pizza, maybe, although I like my local pizza place better than the ones who deliver. But a lot of your clientele were not used to delivery, and particularly, like you said, something that is more in line with what they might either eat at home or that they ate in a prior, where they lived prior or where they came up. So that's very helpful. I know Delegate Young had a question with regard to many of the nursing homes. Delegate, did you want to ask your question?
Thank you, Lieutenant Governor, and thank you, Secretary Kramer, for your presentation. I have a question that focuses more on long-term care facilities, so nursing home and assisted living facilities, many of which have essentially been in lockdown for 5 months now. They are the homes to our most elderly citizens who are suffering, as the Secretary mentioned, from depression, anxiety, uncertainty, loneliness, fear. And as she also pointed out, these things can exacerbate dementia and severely affect physical health as well, particularly since maybe some of the physical opportunities have been curtailed during the pandemic. Many of the smaller facilities don't have internet. The elderly are not comfortable Zooming, and these facilities may not have the resources to help them connect with family via the internet. So they're very isolated. Oh, and another obstacle they have is that as we all age, we're more inclined to suffer from hearing loss. So that also makes it difficult to communicate. So my question is, are there any best practices that you're aware of, or any of the other participants, that finds a better balance or finds an equilibrium between physical safety from the pandemic and the mental health challenges that may present greater threats to our elderly populations living in long-term care facilities?
Yeah, thank you very much for your question. Certainly, that is a huge, huge issue. I am on a call, a national call with secretaries and directors of aging across the country every week. And we spend hours having discussions about what we can do. It's not just a concern in Maryland, it is absolutely a national problem. And we are very, very, very limited in what we can do. And the issue of not allowing visitors into nursing homes is national. And because having one person come in who infects others, it spreads like wildfire. So we do have to be extremely cautious. We have in the department the ombudsman program. The Department of Aging has the state ombudsman and then ombudsmen who practice all around the state. And they are highly trained by our ombudsman, and they are available to take questions, discuss concerns. They are advocates for residents. And so I always first suggest that the family member or the resident themselves contact their ombudsman if they have specific concerns. I can tell you, I got a letter from a woman whose mother was in a nursing home, and her mother would stop eating whenever the daughter, she had dementia, she would stop eating whenever the daughter stopped coming in to visit. So COVID became a huge problem. And she wrote to me and said, is there anything we can do? Our ombudsman from my office got involved immediately and made arrangements for the mother to visit outside. Can't do it on most instances, but in this one, because the mother was really deteriorating rapidly, the woman who contacted me spent the day with her mother. She sent me a letter a couple days later, and she said, I held my mom's hand and we interacted, and she passed away holding my hand, and wanted to say that, and I still get goosebumps every time I think about it or mention that. So and she said it was the best resolution possible. It wasn't ideal. Ideally, she'd have been in there every day, but it was the best possible in an international pandemic. We can give some assistance. I can tell you that around the country, the only things that have been done are provision of some smartphones and tablets in nursing facilities to help people. And we've done some of that in Maryland so that we can provide the hardware for people to interact a little bit, but that's difficult. You noted hearing is a problem. And there is very little. We wanted to start a pen pal campaign with people who live in nursing homes and assisted living. And we couldn't do it because we could easily open up and introduce these very vulnerable older adults to scammers who ask them when their birthday is and where do you live? What's your address? And it's so easy to do that. I want to send you a birthday card. Let me know more about you. So we are currently working on a couple of concepts that we're trying just to create a pen pal program. So to answer your question, there is nothing happening nationally because there is so little that can be done. And when I say nothing, few little programs around the edges like we're working on, bringing the hardware and technology in, as well as a very heavily controlled pen pal type program.
Thank you.
Thank you for asking. We have nightmares about it all the time, I assure you.
Senator Hester, you had a question, didn't you? You unmute Senator Hester. Senator Hester, you still there? She's listed as muted. Senator?
Yes, I'm here. I'm sorry.
You had a question?
Yes.
Okay.
I was curious what the best way is for us to find out, A, if our counties are engaged in the programs that were described, and what we should do if they're not, to get engaged.
Wonderful question. Thank you. Because we have a couple of counties, a few counties that are not participating in the restaurant small business program. And we're very disheartened about that. So please contact me and I would be happy to let you know about what's being done where.
Okay, thank you. I'll have my office call you. Thank you so much.
You bet. Great.
And I'll check to see which counties aren't participating. I don't have a problem
Thank
shaming
you.
them.
Thank you. We're ready to go there, I can tell you.
Okay, all right. Well, thank you. Any other questions for the good secretary?
Great.
Okay.
Thank you very much.
Thank you very much, Rona. Okay, we're going to go to the public testimony now. And I want to say that we ask everyone to keep their comments. Please keep your comments to 2 minutes. We'll start with the elected officials who signed up. Senator Augustine is on, and he is up first. Senator?
Thank you. Yeah, thank you. Thank you, Lieutenant Governor Rutherford. I really appreciate it. I've been very, very excited to listen and take notes during this meeting. Some really great work going on. So thank you for the work that you're doing and this commission. I just wanted to make sure to share with this group that I feel that this pandemic really highlights the behavioral health challenges in our state, particularly with regard to access to care and the utilization of that care. The telehealth really is an important element that I think that we have to really stay focused on the appropriate utilization of that going forward, even beyond the pandemic. I'm really here to learn and to listen to what's going on and just to be a helpful part with regard to some of any legislative remedies that may come forward. So I just want to thank you all very much for all the work that you're doing.
Well, thank you, Senator. And I think we will be talking to you and as well as the elected officials who are on the commission about what we can do in the areas of telehealth in particular, but there may be other areas as well to help move the ball along in terms of being able to address many of the challenges that we have with getting services to individuals in our communities. So thank you. I'm glad that you could listen in and participate. I know that you participated when we were in Prince George's, so it shows your interest in this area, and so I thank you tremendously.
Thank you, Lieutenant Governor. I appreciate it.
Delegate Barron, was Delegate Barron able to join us? I don't think he had signed up, but I know there were some other hearings that were taking place today, so unless I hear from Delegate Barron. Okay, I guess he's not here. Evelyn Burton. Is Ms. Burton available? I don't know where,
She's trying to speak, but she's on mute.
There she is. Did you unmute? You see her? Can you? Oh, Ms. Burton, unmute yourself. I think we've unmuted you. I can see you.
Okay,
Oh, there you are. Good.
all right, thank you. Okay. Hold on one second.
Yeah.
Okay. So, good afternoon. I'm Evelyn Burton. I am the Advocacy Chair of the Maryland Chapter of Schizophrenia and Related Disorders Alliance of America, called SARDA. We're a grassroots nonprofit organization focusing on those with schizophrenia and bipolar disorder. We requested the Commission consider recommending that the state administration apply to the federal government for the Medicaid IMD exclusion waiver for mental illness. Under current Medicaid law, the IMD exclusion prohibits Medicaid payments for individuals ages 21 to 64 to psychiatric hospitals with over 16 beds, called IMD hospitals, such as Shepherd Pratt and Brook Lane in Maryland. This rule is highly discriminatory. Maryland is very thankfully using state funds to pay our IMD hospitals for Medicaid excluded patients, but this funding has been reduced and is capped. However, as of November 2018, states can apply to Medicaid for a IMD exclusion waiver for mental illness for broader access to federal Medicaid funds. Under the waiver, Medicaid would pay 50% of the IMD hospital cost. It requires an average statewide stay in IMDs under 30 days. It also requires the state to enhance outpatient services and show the waiver is budget neutral. Appropriate hospital stabilization will also reduce costs from recurrent hospitalizations and ER visits, criminalization, homelessness, violence, and suicide. Only the IMD hospitals have specialized units designed for severe psychosis that may take longer to stabilize, and units for eating disorders and those with developmental disabilities. Especially during this time of state budget shortfalls, Maryland should take advantage of the federal funds and promote treatment that reduces expensive repeat hospitalizations by applying for the Medicaid IMD exclusion waiver for mental illness. So I hope the commission considers this as a recommendation. Thank you.
Well, thank you very much, Ms. Burton. Thank you for bringing that to my attention. I'm going to turn to Ms. Roddy to see if we've contemplated that.
So I'll be happy to answer that. Ms. Burton, if you've kind of followed what Maryland Medicaid has done, we used to have an IMD waiver years ago. The federal government asked us to phase it out. We reapplied for it. I think it was maybe 2017 or so, and they denied us. You are right. Policy at the federal level has changed. But in the meantime, we also did apply to the federal government to allow us to pay for psychiatric IMD visits where the primary diagnosis has a substance use. So we do actually have that authority currently. We're allowed to pay for those individuals for 2 weeks out of every month. We just had a call around this issue, and one of the next steps is to get some of the private IMDs together, along with our state staff and our ASO, Administrative Service Organization, to see how we can go about and make sure that that billing is happening. And in the meantime, we are looking at potentially applying for a full, as you mentioned, an IMD exclusion waiver. It would be our current 1115 waiver application expires next December of 2021, and so we will be reapplying, renewing our application starting in July. And that's one of the areas that we will consider also after we evaluate how expansive our current authority is. We would hate to give up the current authority if it is actually more expansive than what would be allowed under a straight IMD exclusion waiver. So more to come on that, but it's definitely on our minds and we are definitely looking into it.
Okay, thank you.
For my purposes, what does IMD stand for?
Institutions for Mental Disease. So it would be your private psychiatric hospitals. We have some public psychiatric hospitals, and And basically, the federal rules don't allow Medicaid to pay for those services for adults up to age 64. Children we pay for, and then of course Medicare covers it, but Medicaid is not allowed to cover it for the adult population.
Right, which goes back to something that I've kind of talked about, maybe fussed a little bit about, and I think we need to at some point get into this kind of difficult issue it's my understanding that's a remnant of the deinstitutionalization of people who are severely mentally ill, and I'm not defending what we had done over the years, and I'm using the royal we, not anyone here, and but the whole asylum and how we were warehousing people, and in many cases it just was abusive. But I think we pushed it too far, where we said and again the royal we, the federal government, the locals, that we started essentially casting people out into the streets. They're supposed to go to community service providers, but there's gaps in that system. And in some cases, people have found that the only services that they can get for someone that is suffering from schizophrenia or some severe ailment is in a jail setting, and it's, we have to address that. And I know a lot of that is federal, but and of course everything's money, but and I think it's a difficult conversation because you've got civil liberty issues, but there are individuals who can't take care of themselves, and we can't expect them to take care of themselves. And we just had that conversation. The analogy is to the person who is in memory care. Mm-hmm. We don't allow that individual just to walk out the door if they have severe or aggressive or dementia or Alzheimer's. We don't just say leave the door open and let them wander around, but we do with many others in our society. And so that's, I think at some point, and I'm willing to really hear the other side. And I know, like I said, it's civil liberties issues. We don't want to get back to what we had before, where we were warehousing people, but there needs to be some solution. And this is where I think our federal officials can kind of get in there to help, even though some of the ones I've talked to, they're just not interested. And it's like, but we have to, like, I think, advocate and push them a little bit more, and maybe shame them. That's my word of the day, shame. So thank you. All right. Thank you, Ms. Burton. Schizophrenia and bipolar is a major issue, a brain disease that there's still, the research doesn't tell us, how it occurs. We do know that many of those ailments don't surface until a person is, maybe in their early 20s. So it leads to that other challenge for the family members. Their adult child has a mental disability, and it's very difficult to get them assistance. And so that's something that I'm very much concerned about, as you could probably tell from my diatribe. Okay. Ms. Judith, go on.
Hi.
Did I pronounce your name correct?
Gallant is.
Oh, Gallant. Not Gallant. Okay, thank you.
Thank you for the opportunity to address this commission. I am Judith Gallant, a licensed clinical social worker. Chair of the Maryland Clinical Social Work Coalition and Director of the Legislation and Advocacy Program of the Greater Washington Society for Clinical Social Work. And I must say that I do feel like Commissioner Bahrain and Senator Eckhart have already addressed some of what I had to say, but I'm going to say it all anyway. So one of the greatest concerns I have heard from our members during the pandemic has been about their ability to provide continuity of care, so important to potentially life-saving mental health treatment to all their clients. A client may lack access to the equipment needed for video conferencing or may not have access to the internet, leaving these clients without ability to contact their clinician during a highly stressful time. This is an example of social determinants that can lead to health disparities in vulnerable communities. Other clients may be thwarted by state regulations. For example, in pre-COVID times, someone living in jurisdiction A who had begun office visits to a psychotherapist licensed in jurisdiction B can, under states of emergency currently in place, continue treatments virtually if they have internet access. Right now, regulatory enforcement is relaxed to allow practitioners to treat clients irrespective of jurisdictional licensure. What happens when there are no states of emergency? The issue of reimbursement for telephone sessions remains. While Medicaid has been reimbursing practitioners for services provided via telephone, thanks to Governor Hogan's order, most private insurers have not followed suit. Teletherapy by telephone greatly expands access to much needed mental health treatment. We implore this committee to recommend to the governor, the Maryland Insurance Administration, and legislature to make permanent the changes for insurance reimbursement for teletherapy via video conferencing, and to go beyond Medicaid to require reimbursement for audio-only teletherapy. We hope to see Maryland lead the way in the DMV towards establishing a collaborative relationship between state licensing boards to permit clients to be seen via telehealth across jurisdictional boundaries. Thank you for your consideration, and I look forward to the opportunity to work towards these goals together.
Oh, thank you very much. Yeah, the cross-jurisdictional licensing is something that we've talked about before this pandemic, that, because, we're a mobile society now. In our country, it's quite often that you don't continue to live in the neighborhood and community that you grew up in. We move around, it's very easy. And so if you've been receiving services in Maryland and you move to North Carolina, let's say the family has been, moves, and you have an adolescent or a child, and they've been receiving services in Maryland, they move to North Carolina, job reasons, family, whatever, you have to find another therapist that person had developed a relationship with, felt very comfortable with them, and those services could be delivered, with the right equipment through telehealth services. So that is something we talked about pre-pandemic, and one of the things that my staff has been looking at in terms of at least what we can do to start that conversation about reciprocity or consortiums. Senator Eckert knows that there's the program with the nurses. We've talked about, and there's some movement with regard to, therapists just generally getting, that licensing, that this could be part of that. That you could allow for that person who's licensed in another state to, versus, I guess it's a residency requirement, wherever the patient is a resident, their therapist or doctor is supposed to be also licensed in that location.
Actually, it's wherever the patient is located.
Oh, it's not even residency. So, so the college student, that's a good example. The college student who goes to a school out of state, and all of a sudden they're not, it's illegal for their therapist in their home state to treat them.
Right. Well, the way the pandemic has brought this up for me and for many of my colleagues is that if somebody had a job, I practice in Silver Spring, and so I would see people who work in Silver Spring, but some of them live in DC.
Right.
And so now, with the pandemic, with the state of emergency, the restrictions have been loosened. But once the state of emergency is over, I don't think people are necessarily going back to their offices the way that they were before the pandemic. And
Right.
so how will those relationships be able to continue without that? And I think probably the national issue is much harder to crack. And if we can start with DC, Maryland, and Virginia, just because there's so much fluidity between our jurisdictions, that may be, I think you mentioned the idea of consortium, and that might be a way to at least get started on that.
Okay. Yeah, no, I think you're right in terms of, we have to start small, and that's why, we look at what can the state do, and maybe we set examples for the federal government. And even with the state, the first look is who's our neighbors and work with them. And like you said, the large jurisdictions, but also as we get to other parts of our state that are bordering on Delaware or Pennsylvania, to look at what we can do in those areas as well, and maybe extending even to West Virginia, because these are all very close. No matter wherever you are in the state, I tell people all the time, you can get to another jurisdiction in 30 minutes, barring traffic, from virtually any place in the state. You can get to another jurisdiction. So very good point. So thank you for sharing with us.
Thank you.
Alan, Tien?
Thank you, Lieutenant Governor. It's Tien.
Tien.
Actually, yeah. And very impressed by the conversation and the knowledge that you conveyed. And also, I was a schizophrenia researcher for 10 years at Hopkins, and really share the things that Evelyn said. And I also learned last week from Michigan that 18 states now have reciprocity agreements for psychologists, to provide services across state boundaries. So clearly, and I think more states do that for MDs, but I think social workers very much all should be in the same situation. So I wanted just to tell the commission about myself, my company a little bit, our work, and most important, our partners in communities. I am a board certified psychiatrist, public mental health epidemiologist and biostatistician, prevention researcher, computer scientist, and innovator. And after a decade at Johns Hopkins, I founded MD Logics in 1997. And we have a mission to bring science and practice together with user-friendly, reliable, affordable cloud information technology, really encompassing measurement-based telehealth, integrated node service capture, screen sharing, all kinds of aspects of really data and workflow. And a major example I wanted you to know about is a statewide screening, referral, and monitoring system we now have across Pennsylvania, which is operating in emergency departments, primary care, behavioral health, school, and other settings as a single cloud system that's used in these diverse environments. I also wanted to note and agree with the importance of social determinants of health across the whole age range. I think it's kind of different how you look at that situation for kids versus adults. Clearly related to COVID and the economic fallout with adverse childhood experiences. Think about a 6-year-old kid whose family's been evicted because they couldn't pay the rent. And I want you to know about, if some of you don't know, about a really great resource of knowledge and services, which is called ACEs Connection. So it's acesconnection.org. And they really combine ACEs science and their expertise in convening communities of practice. They have about, I think, 300 across the country. They started in California. So they're a great resource. And then I'm a guy that thinks a lot about words and semantics and how our brains operate. So two concepts I wanted to emphasize are measurement and causality. And as I think you all know, but just to reiterate, measurement is critical for many things that we want to do, right? So it's important for awareness of issues, decision support, collaboration, care continuity, responsibility, learning, and policy evolution. We need data for all those things. The second concept is something, if you look at my presence on Twitter, I have a hashtag causality crisis. And this is my term to reflect that we need to increase understanding of how these factors are all interconnected. For example, with car accidents, opioid overdoses, suicide, other violence, COVID-19 interactions, and really the broad behavioral health problem curve that's been expanding for a long time before COVID and has been amplified by COVID. So I've been doing this for a long time. A lot of experiences and frustration, actually, in various healthcare settings, especially. So we know that user-centered technology is a very important enabler to measure, connect, improve performance, but it's just a part. And really engaging and supporting individuals, teams, organizations, and their linkages is essential to be able to improve prevention, early intervention, treatment, and shared learning. So for that purpose, we've actually recently established a behavioral health learning collaborative of Pennsylvania. And there's a website, bhlcofpa.org. So Behavioral Health Learning Collaborative of Pennsylvania. And that's really led by Drexel University, Jefferson University, Pennsylvania Department of Human Services, OOCC, their Office of Mental Health, student assistance program providers, and other providers. So it's really about getting people together to share information and collaborate. So those folks would be very happy to communicate, collaborate with us in Maryland. So that's a great resource. So I think I'll stop there. I'm excited to talk to all you guys, but I know I only got 2 minutes. So
yeah, well, thank you. Thank you for the information. Yes. Yeah, I'm sorry. I think I was a little long-winded earlier, so we'll need to move on to make sure we get everyone's comments in. Dr. Jill Berghauser?
Hi, yes, Bergholzer.
Bergholzer.
Yes, thank you so much for allowing me to speak. I'm a psychiatric nurse practitioner. I work at a number of hospitals in the Baltimore and Washington, D.C. area, taking care of psychiatric patients, both in the emergency departments as well as on the inpatient units. I'd like to speak to request, like Ms. Burton, to consider applying for the IMD Medicaid exclusion waiver. It's so important that we move these patients to somewhere where they're safe and where they can get care and get long care if they need long care. We're seeing a lot of repeat patients. I had a patient that came to the emergency room on Saturday at one of the hospitals where I work. We had just discharged her the prior week after a 4-day stay, which was not long enough. And she was in the emergency department Saturday. I took care of her. She's still in the emergency department this morning when I went into work, waiting on a gurney with 4 other people, no curtains, nothing, just patients just laying on stretchers waiting for care. We really need to increase access. Thank you for your time.
Sorry, I was muted, so thank you. Yes, it's really a challenge, and so I appreciate your what you're doing every day and the work. Rita Toner. Is she unmuted? You check your computer. There you are.
Okay, wonderful.
All right, and I am here with testimony to recommend the IMD exclusion Medicaid waiver for mental illness. So again, my name is Rita Tonner, and I'm the parent of a son who had a serious mental illness and substance abuse. He died in 2015 of a drug overdose. I'm requesting that the commission recommend that Maryland apply for the IMD Medicaid waiver for mental illness. There's a pressing need for extended lengths of stay in specialized treatment facilities, especially for individuals with a dual diagnosis. My son was regularly hospitalized for medication evaluation, depression, psychosis, relapse due to substance abuse, or overdose of a psychiatric medication. His discharges were often to shelters or back to the space he shared in the basement of a house. He also experienced long waits, sometimes 2 to 3 days in ERs, waiting for an available bed in a hospital psychiatric unit. He once had an extended stay at a local facility, but there was no transitional therapeutic housing available after his discharge. The bottom line, he was never able to be effectively treated for his dual diagnosis. The current IMD exclusion policy is discriminatory against people with mental illness. Applying for the Medicaid IMD waiver would benefit Maryland. It would allow IMD hospital treatment based on medical necessity. It would improve community transition and success following treatment. It would increase financial stability for unique facilities that provide treatment for dual diagnosis of mental illness and substance abuse. The waiver would save the state money due a 50% federal hospital payment and hopefully decrease readmissions and resulting ER visits. And lastly, hospital stays that are longer and more effective reduce ER use, as we all know, suicide, homelessness, and other adverse effects and costs to state and local government. That concludes my comments.
Thank you very much. Yes, and appreciate the request for the waiver of the IMD, the exclusion. I'd also say, and I think I said it before, contact your federal officials too. I mean, we shouldn't have to go through this process, and so we are going to go forward with requests. You heard that we've been denied in certain times, but let's pressure those federal officials.
All right, will do. Thank you.
Mr. Lieutenant Governor, you've gone on mute accidentally, I think.
Okay, sorry about that. Thank you, Ms. Smith. Tiffany Scott. Thank you, Steve.
Good evening. My name is Tiffany Scott. I'm the founder of the Maryland Peer Advisory Council, which is an advocacy and peer recovery support training organizations for individuals in and seeking recovery. I'm speaking today on behalf of individuals within the recovery community, in addition to my personal lived experience with adult child and family members who unfortunately lost their lives during COVID-19. My daughter, Tiara, was 28 years old. She was a resident of Baltimore City, living with a behavioral health condition in addition to a long-term illness. During COVID, she experienced access to services and support, stigma and biases at a local hospital by staff and healthcare providers. After many admissions and discharges, she was sent home to manage her care. On May 17th, she unfortunately lost her life at home behind a locked door. While I was cleaning her apartment, I was overwhelmed to discover Tiara was on 19 legally prescribed medications with a combination of mental health to include opiates. Prior to her death, Tiara took a picture of her hand, which was filled with medications to self-advocate for herself. Since May 17th, I have lost 2 additional family members between the ages of 25 to 30 from opiates. They are all living with behavioral health conditions. I recall a moment during the most recent death when the medical examiner showed up at my relative's house and looked at me and stated, "We have to stop meeting like this." any access. I'm asking the commission today for support for any accesses to services to include strengthening our prescription medication monitoring system, increasing the expansion of telehealth services to include peer services. I'm currently a certified peer recovery specialist, along with 300 others across the state of Maryland. Addressing the digital divide for individuals without cell phone access and services for both mental health and behavioral health services. Lastly, to increase opportunities for peer recovery support workers to include recovery and wellness centers, supportive housing, and crisis centers, which will be extremely helpful. During COVID, these services were cut off. Thank you for allowing me to share my story today. My name is Tiffany Scott.
Thank you, Ms. Scott. Very much appreciated your sharing the story, and our hearts go out to you for the loss of your daughter. That whole question about the medications, and I hate to just blame the feds, but I think I'm going to have to draft a letter to our delegation, if nothing else, and the chairpersons of the appropriate federal committees, because there's this wall that separates what doctors can know about a patient, that if that patient is getting counseling for substance use disorder, that information is not automatically shared with their primary care physician. And the same goes for if they're getting counseling service for a mental illness. So I always give the example, if I'm getting, let's say I'm in recovery for a substance use disorder, and I'm cleaning my gutter and standing on a ladder and it's unstable and I fall and I separate my shoulder, my primary care doctor will likely prescribe an opioid for me unless I tell him, because it's not in my medical record, unless I tell him that I'm in recovery, he or she is going to prescribe me an opioid. And the same if I were, suffering from depression and having counseling associated with depression, and I'm having trouble sleeping, and I go to my primary care doctor, he may prescribe me Ambien or something, and I only know from the commercials I see that they say, hey, if you have suicidal thoughts, you shouldn't take this, or at least tell your doctor that. So that is one of the challenges that we have to address. So it's all in the name of privacy, and it's trying to cut down on stigma, and I understand that. But these are well-intentioned actions taken by our elected officials that have detrimental consequences. And sometimes you judge the morality of an act by its consequences and not by the intentions that were behind it. So thank you very much for sharing, and please excuse me from getting on my high horse on that. Rayetta Michael, did I pronounce that right?
You did. Thank you.
Thank you.
Hi, I'm Rayetta Michael, and I am here to ask that the state apply for the IMD Medicaid waiver as well, like Evelyn Burton was talking about. I am co-founder of Help in the Home. It's an in-home care agency that supports people that have severe mental illness. And over the years, we've seen the average length of hospital stays decrease from 21 days down to 5 to 7 now, with 10 being a long, lengthy stay. And the result is we're looking at hospitalizations as triage for emergency stabilization, not really treatment. And our clients end up back in the hospital within a few weeks. When I learned about the Medicaid waiver, I was talking to Evelyn about that. I said, Evelyn, that sounds like free money. I want to, and that could improve the inpatient care that, our clients so desperately need. And so I made plans to come and talk to you all today. I wanted to tell you about one person. I'll call her Nancy. She lived in our supported living community for 4 years. She was stable on meds. She completed courses at Montgomery College and started working as a waitress and graduated to her own apartment. And then she went off of her meds. And within a few short period of time, the illness, her psychotic illness, consumed her. She ended up back in the hospital less than 2 weeks. She was discharged to a crisis bed. She left there choosing, in a very psychotic state, to live on the streets. And from there, ended up in the criminal justice system, the jail becoming her treatment provider. So we know that hospital stays long enough to provide stabilization will reduce emergency use, suicide, violence, homelessness, criminalization of mental illness, and related costs to the state and local governments. So for me, it seems like common sense to put the time and effort into applying for the waiver, and could be free money from the federal government. So just thank you for hearing what I had to say today.
All right. Thank you very much. And yes, I know a lot of people are advocating for the waiver. And so that we can get through the rest of our people, since we are already past our 6 o'clock time frame, I ask if that's what you're advocating for, that you just make the statement and then go on. But thank you for the story about the young lady. Ms. Carolyn Knight. I think we're not sure that she's on. Mary Moran. Okay. Renee Stokes. I think I saw Renee Stokes' name up there before. Is Renee Stokes still with us? Renee, if you are here and come back, I'm going to go to Gerald Horowitz. Did we scare everybody off? Ellen Weber.
Thank you, Lieutenant Governor. I am here. And I'm Vice President for Health Initiatives at the Legal Action Center, and the center also runs the Maryland Parity Coalition. We've come before your commission in the past to urge strong enforcement of the Mental Health Parity and Addiction Equity Act to ensure access to mental health and substance use disorder services. But today, what I wanted to do is just for a minute reiterate what we've all been talking about, improving access to mental health and substance use disorder services through telehealth. And in adding on to Ms. Gallant's comments, I want to talk about retaining those flexibilities in the Medicaid program. We want to, the coalition has issued broad recommendations with regard to that. 36 statewide organizations have signed on to those recommendations. We have shared those with state leaders, and we've also already begun discussions with Maryland Medicaid and the Behavioral Health Administration on those recommendations. So we thank you for that. We also commend the state for making mental health and substance use disorder services more broadly available to patients in their home and via audio-only communications, both under the federal and state public health emergencies. These, as we've already discussed, these practices have given Marylanders access to life-saving care while they minimize their risk and the risk of others to exposure. It's also helped communities, both rural and more urban, that have no or limited access to broadband, and to individuals who cannot afford computers or internet access. As we know, Behavioral Health Administration has done a survey that has found really widespread favorable responses to that. No question, there are problems that need to be resolved, but access via these kinds of services are essential. So we would like to urge the state to adopt the following 5 practices in Medicaid and to ensure Medicaid reimbursement to maximize access to care. The first is to allow patients to receive substance use disorder and mental health services in their homes or other locations agreed upon by the patient and the provider. Second, we would like to define telehealth in state law to include service delivery by audio-only telephonic communications and to provide reimbursement for those services on par with in-person services, with a federal match. 2 states, Colorado and New Hampshire, have already done that. Third, we would like to have the state revise existing telehealth regulations to remove prescriptive and unnecessary technological requirements for the audio-visual communications, requiring more generally HIPAA-compliant technologies. Fourth, we would like to adopt state licensure requirements to allow a full range of practitioners to deliver services via telehealth as they are permitted to do on an in-person basis. That includes alcohol and drug trainees who provide services under supervision and paraprofessionals as part of a licensed program. And then fifth, we would urge the state to advocate with federal officials for continuation of flexible prescribing practices for patients with mental illness and opioid use disorders, including initiation of treatment with a controlled substance and more flexible take-home medication for methadone as appropriate for those patients. As we've heard today, state data already shows an increase in overdose deaths associated with the pandemic. We know that the rates of mental illness and substance use disorders are going to increase. We think these telehealth services are an essential way of improving access to care. We look forward to working with you on those types of initiatives. And thank you very much.
Thank you, Ms. Weber. I'd also ask you to send us on our email address those 5 areas that you were advocating for, and that goes for any of the other individuals who testified. If there are specific areas that you want us to investigate, please feel free to send information to our email address. Testimony, additional testimony, if there are folks out there viewing from home who weren't signed up for this commission meeting to speak, if they want to submit testimony, they can send it to our email address, which is MBH for Maryland Behavioral Health or Mary Boy Henry .commission@maryland.gov, and Maryland is spelled all the way out. mbh.commission@maryland.gov, and we do accept written testimony at that site. So I want to thank everyone for participating today, our commission members in particular. Thanks to Secretary Kramer for her presentation. And of course, thank you very much for all the members of the public who testified, who advocated, who helped to educate us on the challenges that are in our state, in our country with regard to addressing these very important issues. And all of your comments and advocacy is taken very seriously by us. I was making notes, and I know we have it recorded, and my staff is taking notes, and I know all the other commission members were very pleased to hear from every member of the public who testified, took their time to bring information to us. So I want to thank you very much again, and I'm going to, unless anyone has any additional comments that they want to make before we shut down, I'll open it to the floor. I think we're good. Everybody's being quiet. Probably some of us need to use the restroom, as I had water and coffee. So thank you all. Have a good evening.
Thank you.